Hi all, good morning. We have Dr. Vivek here presenting a neonatology case who came like 3 days before. It's a very interesting case which gives a lot of points on emergency basis. Over to you, Dr. Vivek.
Thank you, sir. A 28-day-old child was taken into ER with a history of reduced response for the past 2 hours duration. Our initial 10-second assessment, patient was not taking any breaths. We checked for pulse, there is no brachial pulse. Immediately, child was taken into resuscitation bay and we started resuscitation as per guidelines. We started chest compression at the rate of 100 to 120 per minute. And parallelly, we have assigned, since we are having our team members ready, I asked Dr. Riaz to take care of airway and to be in head and we are assessing for getting peripheral cannula. Then chest compression was started at 100 to 120 chest compressions per minute in lower third of sternum or line joining both at the level of line joining both the nipples. And Riaz was in head he was managing airway with positive pressure ventilation with ambu bag ventilation. Bag size was taken to be 100 ml and mask was taken up as an approximate size of covering both nose till the lower end of jaw so that it can cover both nose and oral cavity, and adequate seal was given.
Okay.
This is our airway and breathing. In circulation part, we have asked for peripheral cannulas, two peripheral cannulas to get ready, preferably size of 24 or 26 to be placed for our child.
Were you able to place a cannula in this patient initially itself?
No sir, initially we are not able to place. In meanwhile, we have connected the child to cardiac monitor and we are assessing for rhythm.
Okay, so what are the medications given? The patient is in cardiac arrest. You told the patient was given adrenaline, isn't it? Yes. After starting CPR. So how did he give adrenaline?
Sir, first dose of adrenaline we gave through endotracheal tubes, sir.
Okay, so you secured the cannula initially itself. So
no.
You secured the ET tube initially itself.
Yes sir. In our first reassessment, we secured ET tube because in neonatals and pediatrics, most common cause of cardiac arrest, we thought it could be hypoxic, so we secured endotracheal tube.
Did the patient have any signs of any sort of respiratory failure, any sort of color disturbances or cyanosis? Any signs with that?
Yes sir. Child is having cyanosis, sir. Then as per history also, there is reduced response for the past 2 hours and child was not taking breaths for almost over 10 minutes as per history, sir. Okay. So we thought it could be hypoxic, sir.
It could be hypoxic.
Yes.
Okay. So the patient presented with absent pulse. That means asystole, isn't it? You started CPR.
Yes.
And which method did you prefer? Is it the 2-finger technique?
Yes, we preferred since we have 2 rescuers, we prefer encircling technique with two thumbs, sir. Thumb technique we preferred, sir.
Okay.
And ratio of chest compression, we gave 100 to 120 chest compressions.
Ratio in the sense it is
15 is to 2, sir. 2% technique, so 15 is to 2 we went ahead with, sir.
So once the patient is intubated, what change you did?
Yes sir. Child was intubated with 3 size uncuffed endotracheal tubes, sir. Angle of mouth we secured at 9 and we secured angle of mouth, sir, to keep in position.
After intubation, what was the ratio?
After
ventilation,
after securing endotracheal tube, we gave respiration, breathe 2-3 techniques. So every third count we gave bag and positive pressure ventilation, sir.
Okay.
Yes,
so you have secured the like angle of mouth at 9, isn't it?
Yes, sir.
So afterward, did you go for a 5-point auscultation?
Yes, sir. After fixing tube at 9, we did for 5-point auscultation, sir. We found out that air entry is minimally reduced in left lower zones. Okay. So with laryngoscope itself, we pulled out tube of 0.5 centimeter and we reassessed the air entry, sir. Okay. Then air entry was found to be equal, sir. Okay.
So that is one of the major differences between when you encounter a pediatric endotracheal tube intubation and checking the airway, because most of the times the weight may not be matching up to the tube size. So the problem is the length may not be matching up to the tube size also. So when you secure according to the formula, yes, as he told, if it is a 3-size tube, it should be secured at the level of 9 cm. But the problem is, if you don't check it clinically, patient can have after some time bradycardia followed by again cardiac arrest. You may not know what exactly the cause it is. So therefore, clinical visualization and clinical auscultation is always important in terms of neonatology or children in cardiac arrest.
What will be the other reason in tube position changes? You remember that
yes,
when you are intubating, you are keeping the head in neutral position. and you are intubating. After some time, what will happen?
Children will be having prominent occiput, so we should have shoulder blades ready before intubation, and tube will be more flexible, so chance of gagging and tube kinking inside is more
That is
common
one
in
thing, and
neonates.
also when the child flexes the neck, the tube can further
Yes.
go inside. So that is the one problem. When you are intubating in a neutral position and you will be auscultating.
Yes.
So at that time the air entry might be equal. But after some time, when we are re-examining the child or something, when the head position the child just flexes also, maybe a 0.5 centimeter difference itself can make a huge difference. And also if there is any extra length of tube, it is better to trim it off and connect it. That can be, because otherwise it will be difficult to handle and kinking chances will be more. So that is the one thing, always remember, tube slipping and position of the tube can go wrong at any point of time in a pediatric or a neonatal. So that's, again, it is a non-cuffed tube. So it will not, cuffing will not help much to prevent from tube slipping, but still the chances of tube slipping is very, very high in neonatal age groups. Okay.
What is the easy technique of choosing the tube in terms of pediatrics?
In pediatrics, what we can do is the little finger size will be the diameter for endotracheal tubes, sir.
Okay.
And multiplying into 3 will give us the position where you have
Angle
to
of
fix
Angle
the
of motion.
tubes, sir.
Okay, fine. Carry on.
And that will be our.
So you have secured the tube, you have continued CPR,
yes, sir.
and you have
First-
given an intratracheal dose of adrenaline,
Yes,
isn't it?
first dose was given through intratracheal route, sir, endotracheal route.
Okay.
Then we continued resuscitation, sir. Then by second resuscitation or second reassessment also, we didn't have pulse, sir.
Okay.
By the time we have secured a peripheral line,
Okay.
and through peripheral line, second dose of adrenaline was given, sir.
What is the peripheral insecure?
Peripheral line, we secured 24 gauge cannula in
Okay.
arm, sir, in left
What are the
arm.
possibilities of gauges which can be used in this weight child?
Yes, sir. This child is 28 days, sir, and approximate weight would be 3 to 3.5 kg. In 3 to 3.5 kg weight child, that is heavy baby. For large baby, it will be 3 to 3.5. In those kind of babies, what preferred size is 24 to 26, sir. If it is possible, we can put 24. But since our child looks more sick and looks dehydrated, it will be difficult. So one smaller size also, it is fine
How
for
do
us.
you identify the 24 gauge cannula?
Color.
What's the
Yellow
color
color.
coding?
Yellow, sir. Yellow.
Yellow. Okay. So 22,
Blue.
Will be
blue, 26,
26 will be
Violet.
purple or violet.
purple or violet. Okay, fine. Yes, carry on.
Usually go for an IU axis.
Yes, sir. If we have tried more than 2 times by an experienced person, then we will go for intraosseous routes, sir. In intraosseous routes, preferred would be in tibia, upper part of tibia,
Fine. So which are the drugs that you can give through the ET2?
lignocaine, epinephrine, atropine, and naloxone. In neonate, we can give.
So what is the thing that you need to take care when you are giving via the ET2? Same dose?
Sir, dose will be usually it will be higher, sir.
How much?
4 times the normal dose we will prefer in
3 to
And-
10 times, usually that is the recommendation. Minimum 3 to 4 you have to give. And followed by
followed by saline we have to give, sir.
how much you have to give in a neonatal?
Sir,
case?
actually in neonate 2 to 3 for this child it is 2 to 3 ml is sufficient, sir.
Okay. If you are giving 10 ml, like what you given in that will be that itself will cause pulmonary edema and the child can aspirate.
Regarding intratracheal medications, one additional point is, apart from the lean medications, what UpToDate is saying, the vasopressin also can be given through the intratracheal dose. So it is vasopressin along with the lean drugs, which is lidocaine, epinephrine, atropine, and
primary
naloxone.
drugs that been given in cardiac arrest, especially the except the antiarrhythmics,
Yeah.
you can give.
Yes, sir. Then we continued, sir. And third reassessment, we got brachial pulse. We got, sir. We got a pulse. Then,
How do you assess the brachial pulse?
sir, child should be in. Child is lying down position. In cubital region, arm fully extended. We will check for pulse, sir. And
Extended and abducted. Okay.
externally rotated hands. Then we reassess since we got ROIC Sachi, we asked for in meantime we are checking for reversible causes of cardiac arrest, sir.
Till now, what all causes have you identified?
Yes, sir. Till now, one hypoxia we have identified, sir, and hypovolemia we have identified, sir.
Okay.
Then when other causes we are searching, sir. So we have asked for blood gas analysis,
Okay.
and we asked for 12 ECG, sir.
So
And
once you have resuscitated, you have you wanted to go ahead with like further reversible possibilities of cardiac arrest, isn't it?
Yes.
Fine. The patient is in altered sensorium still, or he has improved drastically?
Sir, child have started to move hands, sir.
Okay.
Child.
So what is the next investigation to be done for this person?
Yes, sir. Sugars we have to check for this child, sir.
Okay.
Sugars we check. Sugars it is low in glucometer point
Point of care
glucometer, sir. So we gave a 4 ml per kg of 10% dextrose as bolus. So taking as child as 3 kg, we gave 12 ml of 10% dextrose as bolus for this child, sir.
Okay.
And we are planning to reassess after 30 minutes of giving bolus. In meanwhile, since child is hypoxic, we are planning to start. We have planning to continue IV normal saline crystal.
Okay, so why don't you give a 25% dextrose in this child?
Yes, 25% dextrose also we can try, sir. But some recommendations is according to up to date, it is this 10% dextrose or 2 to 4 ml per kg. In some regional practitioners and centers, they are still following 25D of 1 to 2 ml per kg. They are giving.
The thing is, the 25% dextrose is more of a hypertonic sort of fluid.
26 kg
Cannula.
One thing is that thing. The second thing is when you give a hypertonic solution, there is hypertonic sort of solution. There is high chances patient might go for a cerebral edema also. That's the most threatening sort of complication. And you need a central line if you want to give a 25% dextrose, which is not practically possible in this sort of case scenarios. Right. Move ahead.
Yes,
So you have corrected the hypoglycemia also. So currently you have 3 possible causes of cardiac arrest, isn't it? Okay.
Yes.
You have corrected it. What is next?
Then we reassessed our primary service. In reassessment, airway was secured with tube.
Now, did you give IV fluid bolus for this
Yes,
person?
sir. 10 ml per kg we gave. As
Why did you prefer 10 ml per kg? What's the
In-
dose which has been told in PALS algorithm?
in shock in 28-day-old child, 10 to 20 ml per kg as fluid bolus we can give, sir.
Okay.
So we prefer 10 ml per kg
Okay.
in this child,
Are
sir.
you suspecting any sort of cardiac abnormalities for this person?
Sir, as per we haven't gone into detailed history, sir.
Okay.
Till now, what we know is child is not having any cardiac abnormalities.
Okay. Fine. Fine. So you're given 10 ml per kg IV
10 ml per kg of IV fluid.
Alright. What's the weight of the baby?
3 kg we calculated, sir.
Okay. So you're given 30 ml bolus.
Yes.
Fine. So what is next? What is holiday saga formula?
Holiday sagar is for maintenance of fluids, sir.
Okay.
First 10 kg it will be 10 ml per kg. Then next 10 kg it is 4 ml per kg. Then since then it will be
No, first 10 kg it is 4 ml per kg. So for a 10 kg baby it is 40 ml per hour. For a 10 to 20 kg
4 to 1.
additional 2 ml per kg should be added.
What you're saying is per day. He's saying is per hour. Okay. Fine.
And followed by it will be every after 20 kg every 1 kg 1 ml per kg should be added.
Alright.
Clarify it, so there will not be confusion.
yes, first 10 kg it will be 10 ml per kg. Next 10 kg it will be 20 ml per kg. Then since then it will be 1 ml.
It's okay. We can follow the per hour calculation.
Per hour
That's always better for us because patient might be there for like 3 hours or 4 hours in the year. It is always better to follow the per hour calculation. Fine. Move ahead.
Whatever you have to divide it with 24 hours, then you will get the per hour calculation. That's only difference. The other one you can directly start per hour. So the 24 hour you are calculating, then you have to divide it by 24. So then you will get per ml how much you need to give.
Okay. So you have corrected hypoglycemia, you have corrected hypoxia, now you have correcting hypotension also, isn't it? Fine. What's the next?
Yes,
So you have done with the primary survey, you have corrected all the possible reversible causes, patient has been resuscitated,
Post cardiac arrest.
post cardiac arrest.
yes, our ABG have come, arterial blood gas have come, sir. Blood gas showing a pH of 7.23 with PCO2 of 35 and bicarbonate of 15 with anion gap of 14 and lactate of 11, sir. Blood gas is showing high anion gap metabolic acidosis, sir.
Okay.
That is our arterial blood gas finding. And 12 lead ECG we have taken. ECG is showing ECG is in sinus rhythm with a heart rate of 112, sir.
Okay.
Then
That's what your ECG strip is showing. isn't
ECG,
it?
ECG, sir.
Fine.
Then our now airway is secured and we have connected child to ventilator, sir. In ventilator we have kept a tidal volume of 6 ml per kg. So tidal volume of 24 we have started, sir. And IE ratio of 1:2 with the FiO2 of 50 we have started initially, and we are planning according to
What's the
saturation.
difference between maintaining tidal volume in children and adults? What is the most dependent factor in sort of children? The most dependent factor in children is respiratory rate. Because
Yes,
so you have to set a respiratory rate very
respiratory rate.
particularly of how much for this person?
Sir, a respiratory rate we have kept for this child as 40, sir.
40.
35 to 40 we can keep. We prefer 40 in this child, sir.
Okay, you said the patient is having metabolic acidosis.
Yes,
That
sir.
means I assume that patient will be already in a state of respiratory alkalosis. So that means CO2 is already has been washed out. So do you want to still go with that 40 rate? Because you should not overcompensate, isn't
Yes,
it?
sir.
So in that case, what will be preferred? What will be the preferable range for this person?
So to prevent respiratory alkalosis.
To further prevent respiratory alkalosis, because the
Then
body is already compensated, isn't it?
Already compensated means we can keep it at either a maintenance respiratory rate or at a lower rate around 30,
Okay.
35.
30 to
between
40
30
sounds
or
okay.
40 we can keep.
Yeah, 30 to 40, maybe 35 around. Okay, fine.
So around 8 liters of mint ventilation, let's say
Yes, sir.
8 to 9.
Yes.
That will be easy. So whatever tidal volume you are achieving, multiply it.
So tidal volume was achieved for this person?
Yes, sir.
Fine. So that means the lungs looks to be very clear, isn't it? So the foci has been cleared from that. Okay, fine. Okay, what is the mode of ventilation preferred for this person?
We preferred, we did in pressure controlled ventilation, sir.
Okay. So pressure was set to what?
Sir, pressures in infants in infants in infant mode we kept at pressure of 15:5, and we targeted a tidal volume of 6 to 8 ml per kg. We achieved 20 ml of tidal volume with 15 pressures, sir.
Okay, okay.
Inspiratory pressure of 5 and expiratory pressure of 5 to 5.
Fine,
5 we increased to 6, sir.
Okay, so you have completed the primary survey, isn't it? Now you're coming to the sample history, short ample history.
Yes, sir. Child is not having any allergies, sir. Child is born to a non-consanguineous marriage, and it is a full-term delivery. Baby is taken for cesarean section because of non-progression of labor, sir. And postnatal life is uneventful. Then child was discharged to home in stable condition. Then child developed feeding intolerance in 10th day of life, following which she had shown to a nearby clinician, and as per their advice, baby was on formula feed and breastfeed since then, sir. Since then, child is not gaining adequate weight and child is looking dull. And after this event, for the past 2 days, child's response is further reduced, and baby is not taking proper feeds for the past 4 hours, and baby is fully inactive and irritable for the past 2 hours, and lethargic for the past 2 hours, and reduced movement is there also for the past 2 hours, sir.
So if we ask you the PAT triangle for this case, what could be the physiological intervention required at that point of time?
Yes, sir. If we go with PAT triangle means her tone is low, sir. Child is not interacting. Eye contact wouldn't be there in if we check. If we would have checked before. Baby is not crying. Look is also sick looking child, and breathing respiratory rate is low, and capillary filling time would have been low, and skin mottling will be
So
there.
what you
And
got was more than 4 seconds, isn't
yes,
it? Okay.
Then cyanosis, because of hypoxia, secondary which can progress to cyanosis also can be seen in C part, sir.
Okay, so since you have now secured the ET tube, did the cyanosis got cleared?
Sir, we are expecting improvement, sir, but we have secured ET tube and it has been only over 10 minutes. At that time we didn't get any improvements in
Fine.
peripheral cyanosis, sir.
Fine. So that is tickles. I mean the appearance of the. So what about breathing part?
Breathing.
You
Post.
said there was no breathing when he came to the ER.
Yes,
So there is no breathing, isn't it?
Yes, sir.
The respiratory rate is also
Yes, sir.
very minimal, isn't it? I would say like nil.
Yes.
Circulation part?
Circulation, brachial pulse, we reassessed and we got brachial pulse, sir.
Initially there was no pulse,
No-
but
no
then
pulse.
after resuscitation, like you got the pulse back. Okay.
Yes, sir.
Okay. So you got the CRT.
Yes, CRT is still 4 seconds, sir. Initially it is more than 5 seconds we got. Now it is after fluid bolus it is coming down to 4 seconds.
So the patient is improving. isn't
Improving,
it?
sir.
Okay.
Skin mottling is also there, sir.
Can we give more bolus?
Sir, in neonates, chance of if we give more fluids mean chance of fluid overload is there, sir. So we have to be cautious.
So we only given 10 ml per
10 ml. In our child, we can try or we can go to full dose. That is 20 ml per kg also we can try, sir.
We can maybe an additional 10 ml per kg because as you said, whatever be the initial fluid we had given, there was an improvement, and still the CRP is around 4. We another 10 ml per bolus will not do further harm, but you can be cautious also. So 30 ml, another 30 ml, maybe you can try here.
Moreover, the clinical status is more suggesting that he can be requiring more fluids, because one is the veins are all collapsed, the second is he had hyperlactemia, the third he had all the signs which is more pointing towards severe dehydration. So severe circulatory collapse is a possibility. So you can go up to, according to PALS algorithm, you can go up to 60 ml per kg if at all there is no sort of cardiac compromise. So for this patient, you would have, I assume that you would have secured the primary survey adjuncts also in the form of NG tube and Foley's.
Yes.
Because the possibility of when you give an ambu bag for ambuing for a child, there is high chance that the patient might have gastric distension. So there is chance for aspiration also. So what size of NG tube has been secured for this person?
We secured 8 size NG tube, and after checking appropriate length, we secured it, sir.
Okay.
Length we checked from nose to earlobe, till xiphisternum, and we fixed 8 size tube, sir. And Foley's catheter also we placed same 8 size catheter we placed, and urine output we are targeting as adequate urine output should be more than 2 ml per kg per hour for this child, sir.
Okay. So are you getting any urine output?
Sir, initially when we secured Foley's, only in Foley's and only for 4-5 drops we got, sir.
Very minimal fluid.
Very minimal output.
Okay, fine. So anyways, like you seem to say that patient is in severe dehydration.
Yes.
So we would have given adequate IV fluids also. So you have completed a primary survey, your short ample history. Any positive findings in the secondary survey?
Yes, sir. In secondary survey, anterior fontanelle is depressed, sir. Then head-to-toe exam, child is sick looking, skin pinchability is tenting is there, and skin mottling was there before. Then child is not pale, no ictus, no clubbing, sir. Then we went into systemic examination, sir. Systemic examination, respiratory system, air entry is bilaterally equal, sir. There is no V's. There is no since child is after
securing the ET tube. Okay.
There is no accessory muscles we are not able to check. Then
was there any crepitation present?
No, sir. No crepitations were. Conductive sounds are not there, sir. We did frequent ET suction and we took secretions out, sir. There is no conductive sound. Then cardiovascular system wise, child is having a heart rate of 110 to 130 beats per minute, sir.
Okay.
And apical beat is in normal position. There is no specific pattern of apical impulse which we found. There is no pericardial rub or buoy. There is no heaves, sir. There is no murmurs also. There is no murmurs in auscultation.
Okay.
Then we
so you have corrected the reversible causes. Do you think any sort of patient, is there any sort of foci of sepsis, anything is there? If the patient is febrile, you thought about that point?
Yes, child
because
is,
the patient might require antibiotic shot, so you should always think about sepsis also.
yes.
Because you said the patient had respiratory discomfort, for which patient was shown to a normal physician, for which conservative management was done, followed by which the patient had failure to thrive and respiratory discomfort, everything. So we need to always think about any sort of respiratory tract infection. So was the patient febrile when he came to the ER?
No, sir. A child was not afebrile when he was 2 years.
Okay. So you did any blood investigation,
yes,
point of care blood investigation?
Then we proceeded with our blood investigation. Blood investigation, point of care, CBC and CRP we did, sir.
Okay.
CBC is more than 30,000 with the CRP of 101, sir. Then with neutrophil predominant, sir. Neutrophil is 79%.
Okay.
And platelet count initially it is 3.5 lakhs.
Okay.
So
do you want to give a shot
yes,
of
sir.
antibiotic? In fact, after taking blood cultures and sent for a markers of sepsis also, yes?
We took blood culture, 2 samples we have taken, sir. Then we sent for we asked for procalcitonin also.
Okay.
Then after taking blood culture, we have given the first dose of antibiotic. We gave piperacillin tazobactam at a dose of 80 to 100 mg per kg. We gave after giving test dose.
Okay. Okay, so you have given antibiotics. So you have given IV fluids, you have secured the airway, you have completely reassessed the airway part, breathing part, circulation part. You have given antibiotic also. So next is what? You have to shift to the ICU, isn't it? You have to inform the pediatrics on call, you have to shift to the ICU. Now there is something which is very peculiar about pediatric transport, whether it is intra-hospital transport or in the ambulance transport. What is the things which has to be monitored while shifting the patient from the emergency department to the ICUs?
Yes, sir. Child have to be what we usually prefer. We will do a checklist and we will see whether everything we are doing, sir. In airway part, since child is in endotracheal tube, we usually will give ambu bag and we will shift, sir. So one person have to hold the angle of mouth properly, and child should be in a supine position with towel placed below the shoulder, sir. So there should be one person specific for giving positive the ambu ventilation, sir. That we did. Then throughout the transport we are monitoring saturation and heart rate. Baby is in cardiac monitor throughout the transport, sir. And before shifting from emergency room and before receiving the patient in ICU, we will be checking all vitals, sir. When before shifting the child, this were her vitals. 130 heart rate is there. Saturation she is maintaining 100%, and angle of mouth is 8.5, and a tube air entry at 5 points, sir. We have checked, it is equal, sir. Same thing we will do from intensive care unit ICU also, sir.
Okay. So one thing.
Portable ventilator, you can connect it. That's the best thing.
Yes.
Again, the reasons behind manipulation, everything will be less. So that is a place where when you disconnect and connect it and all, that is the time when you will have the tube dislodgement of the tube, everything will happen. Portable ventilator, excellent. That will be the best option.
We will check the
then sugar
also before shifting.
Sugar is also rechecked. What is the recheck sugar?
Our recheck sugar is 73, sir.
Okay. Okay, you have continued IV fluids also, isn't it? One of the most salient points in pediatric resuscitation is talking to the bystanders, because I think most of the time what we find satisfying is, even though unlike adults, if we correct the reversible cause, most of the time you will get back the pediatric arrest, isn't it? So how did you encounter the bystanders? Initially, what did you talk, and further, like you would have recounseled the patient bystanders. So how did you talk with them?
Yes, sir. We counsel the bystanders.
Because I assume that they were given a history of, since 4 hours the patient was unresponsive or maybe like reduced movements. So you cannot give any sort of guarantee, because it's almost like more than 20 minutes, which has been a protocol which has been set by ACLS and PALS also, isn't it? So it's almost 4 hours. So the time since arrest is almost unknown. So how did you encounter the bystanders?
Yes, very poor prognosis we explained to the bystanders, sir.
Okay.
Chances. First we educated them about what is the condition of child, sir, and we confirmed it, because child is having hypoxia, child was having hypoglycemia. There are more than 2 or 3 correctable causes itself we could have found out, and child is sick, and child have been sick for past 10 days, so it is not an acute event which should have caused.
Yes.
Even though we have resuscitated child, but unresponsive time is more than 4 hours, so chance of brain damage will be high in this kind of babies, and neurological outcome also will be poor post resuscitation. On top of it, child is also having sepsis component which will worsen everything.
Exactly. So that was one thing. The neurological recovery was quite fast in this kid, isn't it? Because the patient was actually able to move his limbs, was able to open his eyes once after resuscitation. So that was, the recovery was quite immense, isn't it? So that is the thing about pediatric resuscitation. So this is a glimpse about a case which came to our ER like 3 days before. Hope you all understood the case. Looking forward to more cases. Thank you.